Well, thank you, everyone, for being here, and we really appreciate you taking your time out of your evening. And so, with no further ado, um, Dr. Nedd, please explain to us your mission now, and talk to us. Whoa, sorry, the wind blew the door. And talk to us about your mission with your new book, Concussion, head to tail, and what that is about and what you're trying to achieve now.
Well, thank you so much for this beautiful introduction. I really appreciate this. And for your listeners and audience participating, we really appreciate you taking the time to attend. So first, I've been around the industry for some time, about 32 years. Well, actually, I've been in the University of Miami system for about 32 years. And my last May marked my last day working in that system. And there I served as the head of the University of Miami concussion sports program. And then prior to this, I was the medical director of neurological rehabilitation at Jackson Memorial Hospital, which is affiliated with the University of Miami. So my training was at the same institution. I did neurology and did a postgraduate fellowship in neurotrauma and neurological rehab. What's amazing about my experience is that I had the opportunity of treating brain injury patients right from the trauma center, the ICU. We ran a service called the Intermediate Brain Injury Unit, which is a transition between the ICU and rehab. My last appointment was as the medical director of neurological rehab. And then I ran several post-acute programs, both in the private practice setting and in the rehab setting. So this is, like you used the word, it's been a journey for me. And what I've learned is that brain injury is the most complex disease of the most complex organ, which is the brain. And the other important lesson is to focus on the natural history of how brain injury evolves. It's not just one disease. And part of the challenges that we faced with in our industry is that professionals in brain injury fail to understand the nature of brain injury, how it occurs, and how it evolves over time because of the complexity of the brain. And so in my work, after seeing, we estimated with the calculations, I maybe had over 250,000 patient encounters of seeing different patients with brain injury. We had part of the blessings I had in that's a positive side of the brain injury experience, and that is being in a major medical center in Dade County that for over 20 years was the only trauma center in the entire Dade County, which is about 2 million population. And as you know, Miami is the seat of trauma. And we've seen all kinds of trauma. So I've been able to see a lot of disease and understand some of the challenges. So outside of the clinical research and understanding what's in the medical literature, this was a natural laboratory for me to look at the nature of brain injury and what we normally call it, understanding how the brain becomes disorganized by injury. My belief and my philosophy and the philosophy of the teams that we work with is that brain injury represents a disorganization or disruption of the organization of the brain at all levels. So from a clinical level, we see this level of disorganization in the way we process information, the way we behave, the way we experience the world, and the way we react to the world. To the physiological levels, starting literally from the molecular level, to the literal functioning of the brain in terms of the messaging center systems, all of those becomes disrupted by trauma. And different types of trauma could cause different levels of disruption and in different parts of the brain. And that ultimately results in the outcome, or what we call the clinical outcome of what you get as an individual with brain injury. Like you were saying a minute ago when you had trouble finding the right words. You know exactly what you want to say, but you just can't get that word out. In the past, people have used illustrations like, okay, the brain works in a way that you have cabinets, although it's more complicated than that. And you just pull the wrong drawer open, or you can't get the drawer open to get what you want out. Again, some people have said that scenario is outdated, but it does have some relevance. The idea is that over time, when you look at the brain, it follows what we call the developmental sequence. When you're born or as a baby, all right, your brain is developing. In that sense, we look at the brain as a hierarchical structure. Hence the method that we created called the BETH method, the Brain Hierarchical Evaluation and Treatment method. Hierarchy means levels. If you look at my book cover, you see this type of steps. And part of it, philosophically, that means how the brain is organized from head to tail. And so there are two concepts. One is called ontogeny, which has to do with the developmental part of when we're born, going from a baby to adulthood, how the brain actually organizes itself and develops. And of course, as we get older and we have some degeneration of the brain systems, we actually deteriorate in the same order. So you develop in an order, you get to the pinnacle, and then the brain deteriorates. That's called ontogeny. Phylogeny has to do with how we evolve in terms of the species, in terms of the development. So at the most basic level, we have what's called tail activities. These are simple activities. And in the brain, the simpler the activities, the less sophisticated the nervous system. So if you look at the spinal cord or the nerves, they are a lot simpler, so they have simpler functions. But if you look at the brain, where you have to think and read and write and memorize and have emotions, those are more complex. So take vision as an example. One side of the occipital lobe, where the visual cortex, has over 160 million nerves, as compared, right, to the knee jerk. Just if you tap your knee and you jerk, that your knee jerks when the neurologist hits your knee with a hammer, it's an automatic behavior. Only 3 neurons are responsible for that. So it's a very simple activity that doesn't require much sophistication from an organizational standpoint. But when you think about reading a book or experiencing sight, you have to look at shape, you have to look at movement, you look at colors, you look at forms, you look at expressions, emotions. All of those have to be integrated, so that system is more sophisticated. So when you injure the most sophisticated system, the more injured it is the more difficult it is for that system to be restored, because it has more organization. I like to think about it as driving. I remember the days when you drive a car that's 6-shift without a lot of electronics. Those cars are really easy to fix, right? But if you get a new car and you have all of the bells and whistles in that new car, it's more complicated to fix. You need another machinery to fix that machinery. So that's a simple way of understanding how the brain is organized. Now, in my book, the BETH method is based on understanding this hierarchical organization of the brain and this hierarchical disorganization of the brain, and coming up with methodologies as to how to reorganize the brain and fix it. I see you want to ask a question. Is that, you wanted to ask a question? A comment?
Me?
Yeah.
I just
ask a question.
I just really like how you put it earlier. I never heard anyone put it that way, but you did really have like a natural laboratory to watch all of this stuff. And I just got off the phone, or Renee and I just got off the phone with John and Barb, and part of their frustration as parents of a patient with a TBI and caregivers now is there's never been any discussion from the trauma to going home about what to expect, what may have changed, and you know, you talked about that, how, you know, you got an opportunity to go through those steps. And I just was telling Renee, we need to make sure that everyone knows where they can get your book, because I have short-term memory loss, perhaps with a little bit of brain injury. And so before I forget, that was what I was going to say is we need to make sure that we know, people know where to get your book. And I know that Ellie was saying it comes out on the 10th, but it's already out now.
So the book, yes, it was shipped, and it should be available on Amazon. That's the primary site you could get it. It's the book is called Concussion, Traumatic Brain Injury from Head to Tail. We could send you guys the connection, so at least, in fact, that's what it looks like.
There you go.
Yeah.
I was looking for the picture I have so that I could hold it up also.
Yes, you got it. Okay. The whole idea is that you could get it on Amazon. And by the way, anyone who's had a chance to read it would love to see a review about the book and what their thoughts about it. And we also have a website, concussiontbi.com. And we have lots of blogs that we're coming up. Some we've done already. And we are touching on various subjects in the book. The blogs would be about chapters in the book. And the book actually addresses some of the current issues in brain injury, some of the burning issues that families want to know about. And a point that you just made when you commented there, very important. Just today, I was talking to a patient, and when you look at what's happening in the financing of brain injury with the insurance companies and the hospital systems, and it's a real tragedy that the community of people responsible for paying for the services is so disorganized. In that we spend so much money on saving the lives of our patients. And when it gets to the point where we need to help them reorganize their brain and become reintegrated in society, there's no money left. And those are issues that are burning. When you think from a policy standpoint, our legislators have little awareness of this issue. Things like returning to work, returning to play, getting people functioning in society. And when you think it costs millions of dollars to take care of a patient in the ICU to get them to the level, and then when they leave the hospital, they go home, they give them 20 days of rehab, and then 30 days of outpatient services, not to realize the long-term effects of this on the patient, the family, society. And one of the things I've observed in my practice is the disruption that we see in society because these patients go untreated. Just look at the justice system. You know, everybody's talking about now this whole rights of people. You know, people with brain injury are at a very much of a disadvantage in society because the police don't understand this. They get stopped and get arrested many times for things that they shouldn't be arrested for because they can't communicate effectively, or maybe they may respond in a certain way that the officer may not be able to respond to, because that's a population of, I see this all the time. And even the courts and the justice system, people get put in prison. They're found guilty for things that if the judicial system takes the time to understand those kinds of situations, we will be able to help most of the people with brain injury. And this disease is so pervasive. We don't realize how much it impacts on everything, your social interaction, your ability to cope, to deal with your family, your marriage, your work. I mean, it's so pervasive. And unfortunately, looking at the studies out there from an epidemiological standpoint, the world has paid very little attention to understanding how much brain injury is interwoven in all of the fabric of our lives and our society.
You know, I know that you and I had briefly talked about this on our last discussion that we had, but I think that you had mentioned that you get an opportunity now to work with the mental health aspect of this and the state hospital in figuring out what percentage of people are actually struggling with brain injury, or did you mention that to me before, or am I making that?
Yes. That was one of the topics we chat about. And it's interesting that brain injury as a disorder is misdiagnosed. I get patients with autism that have brain injury. with bipolar, which is perhaps one of the most common
Yes.
misdiagnosed. They come up because of the changes in mood and in certain behavior patterns. And they're diagnosed as bipolar. They have very similar features, but they're a different disease. People with bipolar disorder don't have as much intellectual issues as a person with a brain injury with a similar picture. And the medications we use may be different. The doses may be different. But what happened, these people get put into psychiatric facilities and they're treated like psychiatric patients. So they get the wrong doses of medications. They put in, and they get worse oftentimes. And they get they overutilize psychotropic drugs in many of these patients. I've seen patients diagnosed with schizophrenia, or major depression. So these are all conditions that it's mistaken for. And in my book, I talk about that, how much brain injury, and give lots of examples of patient stories that illustrate this point. So, so that's a good point that you brought out in terms of us properly identifying and diagnosis. One of the problems we have in modern medicine is we use what's called a cluster method of diagnosing diseases. So if you have this symptoms plus that symptoms is equal to this disease. Well, in brain injury, you have to look at it from a hierarchical standpoint. You have to understand that a person, one part of the brain could be injured, another part of the brain could be injured, and they look identical. But it may be, and you could misinterpret where it's coming from. So because of the connections, the brain is so intimately connected. So even though you get hit in the front of the brain, right, and you may have an injury in the front of the brain, you may find that something functional in the back of the brain may look impaired. But it's just because of the connection between the two parts of the brain, it looks like it's coming from the wrong place. So you could also misdiagnose someone in terms of localizing where the problem is. And so this is why understanding the whole networking of the brain and how that works, very critically important.
And that speaks to so many of us. I know there's a couple people on this call, and Shane even spoke up and said he can attest to the fact that brain injury affects everything. Even though some things are so strongly affected, other affected parts become forgotten. And it's so true because we're so focused on getting from A to B, all of the outside of everything, just it's like being in a whirlwind. You just got to get forward. But some of us on here have talked about the personality changes and how people say, well, you never did that before, or you weren't like that before. And I think maybe you're just depressed. And you and I talked about, the psychotropic medications and the allopathic method that we just automatically go to, where we want to prescribe something for something we don't quite understand because it sounds like something else, and then we miss the mark, and then we've created another problem in and of itself, and the rewiring of the brain and how that all works. But we also talked about standardizing some testing, because there is no standardized test for the brain. There's no baseline for athletes. So what do you talk when you talk about that? What do you propose, or what's that look like to you?
Well, first, let's start from the last one first, standardization. One of the problems of standardization is, first, you have to have the ability to compare patients in a similar fashion. So you have to group patients in categories that they could be compared to, because it's such a different disease from different persons. So, and that's why it's multidimensional. So you look at an issue of how severe it is. Okay, what part of the brain was injured? What's the mechanism of the injury? Okay, just something as simple as that. Somebody having a motor vehicle accident versus someone falling and hitting their head has totally different outcomes in terms of how the brain is injured, what you expect to see, and what the outcome is. So, and then of course, there are psychosocial and emotional factors, your upbringing, your educational background, your family support system, all of those dimensions, how much time elapsed from when your brain injury occurred to when you started a particular treatment. So in order to compare apples and apples, you have to take those dimensions and take a cohort or a group and put them in the same category. Then you could say you're comparing apples and apples. And many of the studies, because of very poor definition and characterization of brain injury, if you read the literature, a lot of the data have been falsely compiled, so that in order for us to really understand brain injury, we first have to categorize the disorder. And that's one of the reasons I came up with this hierarchical approach. It's a multidimensional approach, which I've called the Beth method, that allows us to be able to first understand what a brain injury is. Once you could do that, you're able to do good research. In the book, I actually addressed this and gave some models of how we could do that, and use the concept of brain organization as the basis for including all of those dimensions. So the degree of disorganization is one common output factor that gives us a chance to be able to do those kinds of assessments. It's only then you could come in and say what kind of therapeutic methods you could use for that group of patients. There are many good methods of treatments that might be out there, but because we apply them at the wrong time, the wrong patient, we come up with the results that are not positive or results that are pretty much negative. So I think the whole science of brain injury has to change in their approach. And that's why I've postulated this model in the book called the Beth method.
I was looking at the last post you put up, and just for you to be able to break down the brain, and I'm just going to share it real quick on the screen so people can see. The front of it's broken down into 4 sections. And, you talk about how it's the command center where all the actions are set up and executed. And we work with a lot of people with frontal lobe injury from MVAs or, just random issues. But, until this point, I had never seen it broken down like this, where we can be like, okay, look, there's this section is affected, and I can see that now clearly because it's been explained to me, But going back to what you said about grouping everyone together and whatnot, this needs to be, in my opinion, and I know we shared this before, this needs to be a collective effort nationwide where people, doctors, physicians, hospitals, adopt this and recognize that we need to do more controlled research, if you will, where we can say these people have been subjected to this or this is, factors that were external or upbringing, environmental factors versus injury factors. Because we notice a lot of overlap also with, like, say, depression. If a patient had depression before, or they struggled with some issues before, that may be extreme now that they have a brain injury, or before they didn't have any depression, they weren't on any medications, they had a great life, and now they deal with depression and mood swing, and now their family or caretakers want them on medications for that. And so there's definitely like this, there's a place for it, then there's not a place for it. And what's your take on like initial treatment? Because you talk about, length of time lapsed and, treatment methods. What's your take personally on medications, specifically like antidepressants or SSRIs or whatever for brain injury?
Very complex question. I almost could, in fact, I'm writing the second book right now on the Beth methods for treatment. What treatments I would recommend for particular types of brain injury situation. And there is a role for medication in the treatment of brain injury, but one has to first understand the medication and its effects, where the medication works, what parts of the brain. And part of the challenges you have is targeted therapy. When you look at medications like an SSRI, those are complex medications. They affect many systems in the brain. They affect your hormones. They affect different, what we call neuropeptides or neurotransmitter systems. That's the neurochemicals. And they work at different junctures in the brain physiology. So we first have to understand where those medication works and all of the cross relationships between those medications. So something as simple as a blood pressure medication that you take for your blood pressure, it does affect a lot of brain function. So you have to look at drug-to-drug interaction, to look at different persons' bodies, how they react. A female react different to a male. A person that's a child may react different to a person that's a senior citizen. And so understanding those issues allows us to be able to pick the right medication. So first you have to define all of those characteristics. When you sit in front of a patient, getting good historical data and information about the patient's situation, where they are, not just the brain injury, what's the outside environment. We talk about mind-body relationships. Some drugs could cause depression, but they may also improve certain situations. Okay, you heard of using different stimulants. Some stimulants work great for improving your processing skill, but it may cause someone to become spastic or have a lot of tone, and that might affect that person's gait. May cause a panic attack, may cause the patient to lose weight, lose appetite. So different drugs have different impacts. So when you treat a patient, one has to have a complete listing and understanding of all the issues. It's not just saying, give an SSRI and you're going to solve the problem. You could actually make that patient worse. And again, part of the problem we have is in our clinical settings, particularly in the acute care settings, we are reflex in our administration of drugs. I've seen in most of the hospitals that we work at, a patient is agitated, okay, after they've come out of surgery or while in the ICU, and the first thing is the nurse says, oh, we need to sedate them, or they're going to pull their tubes out. So the hospital is more concerned about them being sued sometimes, so we end up using excessive amounts of medication sometimes to manage patients. Sometimes you have to. And when some of these medications may have short-term and long-term effects. Now, I could also say not using enough sedation could also have long-term effects, because the emotional memory of someone doing a procedure that's painful could actually cause a patient to have long-term post-traumatic stress disorder. So it's a balance between when you use a drug and when you don't use it. And that requires a lot of training, a knowledge of neuropharmacology, a knowledge of just the clinical knowledge of understanding how to take a good history and understand the entire environment of that patient. And not only that, but you have to have general medical knowledge of what else is going on with the patient in terms of their situation. So I do use medication in my practice, but I try to use it in conjunction with all of the other issues that we're dealing with.
And I respect that more than you will even understand, because you actually, and we talked about this, part of why I wanted you to come share all of your wisdom in your journey, you actually care about the health of the patient and the long-term health of the patient, and you listen to the patient because your goal is to get them better, not just to get them by. And
exactly.
Unfortunately, so many of us probably even on this call, and I know we did personally, we ran into we're going to get you out of our office. We're going to get you by. You're going to be okay. And it was just go ahead and go home.
If you go online, you'll hear comments about Dr. Nedd. Patients have to wait for a long time. I take a lot of time with patients. And that's because you can't just rush them out of your office. This is a disorder that you have to sit and listen. It takes time. Most of my patients, average, I spend 2 hours, hour and a half even on a follow-up. But
I
you
saw
have
that.
to take the time, because you'll be surprised what you get from patients when you listen to them. I mean, I'm not smarter than any doctor out there. The only difference between me and other physicians is that I take a lot of time in listening to people. Some things that seem irrelevant, and I'll tell you, in this day and age, the whole nature of medical practice has changed so radically over the 32, 34 years I've been practicing, to where, because we have so much technology available, people substitute technology for good clinical evaluation, asking questions, getting good history. And that's why we missed the boat. So it's the quickest thing to do is, okay, what did the CAT scan say? What did the MRI say? What did the EEG say? And we missed the boat that the patient may be having sleep disturbances. They sleep cycle. They have trouble falling asleep rather than staying asleep. When the nighttime comes, they get panic attacks because they sit in bed, they can't shut their brain down. All night long, they're thinking. Simple question. If you sit and you ask the patient, why are you having this problem? They overactive limbic system, so they can't shut their brain down. And the reason why they can't sleep is not because they have a sleep disturbance, it's because their brain is working on overdrive. They can't shut their processes down. And if you really listen, you could treat that problem simply. And they don't need a sleeping pill. What they need something is to cool down their limbic system so they don't have racing thoughts at nights. And those are simple things. If you just listen to the patient, you understand the methodology that it takes to manage these complex patients.
I'm laughing because we went through every single aspect of what you just described, from being on Ambien and Lunesta and everything else, and then finding that a little bit of prazosin for blood pressure is the key to getting me to sleep for 8 hours.
No, it's amazing. Prazosin is a great drug. I love using it
because I was having night terrors.
Yeah. And it's great for PTSD, post-traumatic stress disorder. Yeah. It's an amazing medication, and we've been using it for years. A lot of the people coming back from the military, it's quite effective. It has other side effects, but people have nightmares, bad dreams, and so forth. They can't sleep at night, and we use this for many of our patients. Yes, you're right.
Well, we had to do the research, though, and find that they did clinical trials in Washington, in the state of Washington, with returning vets, and found out that, these guys had been on hard medications and Lunesta high doses and this and that and the other. And then, through trial and error, found out that little bit of a change in just that, because like you had mentioned before, it's so interwoven and connected. And it was crazy to me. It takes 3 neurons to fire your knee, and look at the response that gets.
Yeah.
But there's so many in one little spot in your brain, and no one pays attention to that.
Yeah.
Wonder why I hold my arm up like this sometimes, or I can't swallow because I have problems with dysautonomic.
Autonomic, yes.
Yeah. And it's stuff you don't see, and that's what Shane was mentioning. But all of these little things add up. And in your defense, I want to say I did read that review. That lady said, you may have to be prepared to wait, but it's worth every second. And everyone else on there said that you're the best neurologist they'd ever seen in their life. So, I mean, that speaks for itself, because all of us here have a nightmare neurology story. David has a question. Let's go ahead, David.
I can add to that, and I don't have any academic or intellectual comments about brain injuries, but I can add to that about Dr. Nedd. And I think I've been with him for over a year, and I've had to wait for him many times. And we felt it was worth it because of what we would receive from Dr. Nedd. And just to add to some previous comments, initially with my injury, I'm sure I saw 4 or 5 doctors. I can't recall them all because I had a few surgeries. I do remember Dr. Clem did my original surgery with my head. I do remember him. But finally, my wife, who saved me, gave me CPR, got the ambulance for me. She looked up Dr. Nedd, and she was intent on me going to see him. So she finally got me in with him. And when we went there, I can recall it vividly that he, just like he said, he listened to me. I felt that I contributed to the discussion, that he heard me, and he said two very important things, and it stuck with me, and I think it convinced me to keep going and stay with him. And he said, I treat the person in front of me. I don't treat just the charts or the graphs. And I never heard that from a doctor. I always heard kind of the opposite, if it stuck with me. And that stuck with me because I felt that he heard me as a human being, and it made me feel good. And he said one other thing, I don't know if he'll remember, but he said, I must have said either something funny or had a little humor. And he said, well, it's good that you still have your humor, which I kind of chuckled to myself because I thought, well, wow, that's pretty cool. But it's the way he dealt with me that led me to believe I was with the right person. Now, he'll probably chuckle because I'm not the one to believe in the medicine I take, the pills. I don't notice anything, but he's spoke with me about that it's doing things that I'm not going to know. But I'm still going through with it and hopefully getting
That's
better.
awesome, David. And you know what? I'll bet you other people will notice before you. That's one thing that we typically find out is other people will notice the change before you do.
Yeah. Well, my
Yeah.
wife noticed many things about me that aren't the same. And me, I'm not objective, as we have discussed. I believe I'm getting back towards being normal. I actually run about 2 miles a day, or at least 6 times a week. And I've been doing physics and math for Dr. Ramundi, 10 hours a week at least. And I do a little light computer coding to convert it into math symbols. So I used to be a physics teacher for about 30 years. So I had a lot of experience and I was good at it. And hopefully I'll get back there.
You'll get to right where you need to be. Your journey is going to change many times, my friend. Just be flexible. But thank you so much for sharing that about Dr. Nedd. He needs to hear that. So.
One last comment. I'm going to make him laugh. Others laugh, but he did tell me something else I do remember the first day. I'll probably make my wife laugh. He said, just remember, I don't know if he'll remember this, just remember you need to be patient with this injury. And at that point, I'm thinking, okay, patient. So a couple of weeks, I can go back at it.
Yeah.
That to me was being patient.
6 weeks with a broken leg, you're good.
Now it's been a year with him. So
awesome.
Patient is a different definition for what he was thinking at that point. Okay, I've talked enough.
Well, thank you very much, David.
Thank you, David.
So, Dr. Nedd, I want to talk about your book really quick. Rick has a question, but you talked about your second book and your treating stuff. I'm anxious to look at that because I have so many questions. I want to do this for like 3 more hours, but
we can break it up if you want us to come back again.
We do. We absolutely do. Yeah. But I just want to, again, before we move into letting Rick ask questions, I just want to thank you again very much because you are an amazing person that clearly wants to make a difference. And that's one of the things that drew us to you is it's not just your ability to heal in a clinical setting. And this is, I think, what David wants to impress and why Chris is here. It's and probably some of these other people I don't even know. It's your humanity and your heart that heals a lot more than you even understand.
Well,
so that's what we really want to commend you for also. on top of all your other academic and clinical doctoral achievements, because those are amazing as well. But it's you as a person that heals other people, and that's not something that can be taught. So I'm going to let Rick ask his question really quick. Go ahead and unmute yourself, Rick.
Can you hear me?
Yep.
Hey, well said, Heath. I agree. Dr. Nedd, my question is more about, it's probably covered in your book, is how to treat people, the initial diagnosis is do we do, like I had MRIs done, scans, but and I also went to progressive rehab, and they kind of analyzed me, but there was never really, I didn't feel like they really understood what I was trying to tell them, what had happened with me. And I was like categorized and given drugs right away, placed in, basically I was just sent one way. This is what's going on. This is where you go. My question is, would it be better to be analyzed by a group of people, or would it just be, how do you approach that when it's such a complex injury?
You answered the last comment. Probably your comment is clear. You need a team to treat brain injury. You don't need just one captain. You need a captain, and you need a lot of other disciplines. But as the captain, you have to understand what are the elements that each discipline is able to treat, and you have to understand their capabilities. That's another part of designing a treatment model, is that you have to know the kind of expertise that you have on board. Because if you have one weak link in the chain, then that chain breaks. So that's an important part of building. And one of the challenges that frustrated me over the years in the models of system I was operating in is that the bureaucracy in the system never allowed you as a clinician to build the right team. And that's a national problem that exists in brain injury programs all over the United States. You might see a section of my book that's a little bit controversial. While I compliment highly the place that trained me and all of the people that trained me, I also offered some critical comments about limitation that these systems face. And that's not only unique to the system here in Miami, but that's going on all over the country. There's a lot of disruption and confusion among the professionals as to who should treat what and who is qualified. That is sad, because when you look at some of the other areas in neuroscience, like stroke and those other areas, they're organized, there's research dollars, people are spending, the pharmaceutical companies are involved, the government is involved, there's research grants. In brain injury, it's not like that. It's very disorganized. And there's not a passionate leadership from us medical professionals. I'll tell you the honest truth. I think more leadership in brain injury is coming from consumers, the people and their families who are affected by this, than the brain injury community. And I hate to be critical about my own profession, because that's what it is. Now, I do see some fundamental changes occurring for example, in our national organizations. But there's a lot of infighting going on in our business as to who should treat what. And I think that's a fundamental challenge that brain injury people, the persons with brain injury, face. And if we fix that, I think we'll be well on our way, including the former comments that I made. And also, so training is important, the ability to build a team, have an organized approach, all those are critically important.
Perfect, great, thank you.
And thank you very much, Rick, for chiming in. That was a great question. I think that's on point. It's part of our awareness that we are working on here with Oregon, and our advocacy is, like you and I talked about before, Dr. Nedd, the fact that there's so much difference in how we're managing it nationwide, from even just 2.5 hours north of us in Washington. They have state money that is allocated for brain injury research, for brain injury programs, awareness, advocacy, school stuff. And with us in the position that we're in, Renee is working on, she's the assistant executive director right now and working on becoming the executive director as we transition of the Brain Injury Alliance of Oregon. What we're inheriting is a great big debt, really, if we're going to be honest. And it's not by anyone else's fault. It's that there's absolutely no funding for brain injury in Oregon.
That's true. And that's all over the country. It's state budgets have been cut on a regular basis. I mean, it's amazing what's happening in our state. We had a impaired speeders drivers trust fund, and that money is every year being cut by the legislators. It's really sad, and we have to fight. I mean, they need advocacy at the federal, state, local levels for people with brain injury. Even at the insurance companies levels, that is where we're going to get the traction. We need to devote more money, more organization, more talent. All of that's needed in the field.
And I agree wholeheartedly.
And also the pharma world, for the pharmaceutical companies and the companies that are building medical equipment and so forth, we need to put some work in those areas.
Yeah, we need to hear from those people that can make a difference, that are in a position to do so. And more people like yourself, because like you mentioned, and this is one of the things that we found out, because we were and are still, you know, on the consumer aspect. But do you know that everybody that deals with the exception of maybe 2 people that are on the board of directors for the BIA of Oregon, are consumers? Thank you all, seriously, for all the work that you're doing and that you're going to do, because I know that it will make a difference. And Rick has another quick question, I guess, real quick.
Sure.
I can't unmute you. You have to do it yourself.
There we go. This is a quick question on, as far as the state level for trying to advocate for funding. I mean, where do we start? Is it the governor level? Is it the legislature? Where do you start? Where's the best?
We have a pretty good handle on that, Rick. We can talk about that later.
Oh, okay.
Yeah. Every state is different. So
we actually have a TBI, a whole TBI committee for that, and we're working on getting some funds allocated. But it's a matter of where you get them from. That becomes the discrepancy.
Exactly, because you always take it from somewhere else.
Yeah, because nobody wants to pay for it. That's called politics.
Yeah.
We think that's a great idea. Who's going to pay for it?
That's right.
So, but thank you very much. It's 6:30 here, so it's 9:30 your time, and we've taken up our time. If anyone else has any other questions, or want to say anything to Dr. Nedd before we get off here. Or if Dr. Nedd, you have any?
If I could just say thank you, Dr. Nedd, of course. And I'm here in West Palm Beach. Maybe I'll come down to Jackson Hospital before I go back to Bangkok, hopefully. Get a chance to see you.
Not a problem.
Yeah.
My office is actually in Doral.
Okay.
Doral, Florida. I have an affiliation with Jackson still, but I don't work for them anymore.
Okay, where is your office now at Design Nurse?
I'll give you the address. It's 8875 Northwest 23rd Street, but we'll provide this to you online.
Okay, awesome.
So we have a brain injury center here. It's called the Design Neuroscience Center.
All right, okay, wonderful. It sounds great.
I look forward to seeing you again. I am so proud of you, I have to tell you.
Thank you so much.
Grace is a trooper.
And David the same.
4 years, so yeah, looking forward.
Yeah.
David.
Thank you.
Okay, David, thanks. Rick, everybody, we appreciate you guys attending. All right, guys.
Thank you very much. And Ellie, thanks for all your help. It's been wonderful to work with you as well. And I encourage people to check out your website, to go to your Instagram and see some of your video series. You have YouTube, correct?
Yes, we have YouTube. We have if you go on our website, you can access anything.
And
it's
give us your website.
concussiontbi.com. Simple. concussiontbi.com. And concussiontbi.com. And we have, you would see, we will feature many blogs addressing various chapters in the book. You're saying something? Oh, video blogs. I gotta get familiar with all those terminology. We call it vlogs now.
Wow, yeah.
Yeah. And we'll produce podcasts, blogs, also some more textual information we'll provide. What we're doing is working with. We are creating a resource that others could use, and hopefully we could use others resources that others have used. So no pride of authorship. Everything we produce, it's available to the whole brain injury community and anyone else that would like to access the information and utilize it.
All right, we appreciate that, and that's one of the things we share. Is it's not about us; it's way bigger than us.
Absolutely.
We're just trying to facilitate that accessibility. So,
well, first, I want to also thank you guys for the work you're doing, and you guys are tremendous. I mean, we've been following some of your stuff on the service, and it's amazing some of the work that you guys are doing.
oh, thank you
Thank
so
you.
much. I
Thank
really
you.
appreciate that. That means a lot coming from you. So,
Yeah.
it means a lot every time we hear it. But thank you everyone for attending, and to everyone that gets the recording, we hope that you found value in it. We know that we did, and we really appreciate everyone, because you're making an investment in your future and yourself, and that's the most important thing we can do every day. So keep fighting. I know that sometimes it's hard, but it's worth it. If things do get better, may never be what they were before, but I promise if you embrace it, it will be better than it was before.
Powerful words, I have to tell you.
That's
Very
very,
powerful words.
very strong. Good.
Thank you so much.
Thank
Thank
you.
you very much. Everyone
Thank you,
have a great
everyone.
night.
Have a good night. Yeah.
All right, take care.